Just 2 seconds. I forgot I can't see any of my notes when it's on this view. Okay, great. So I know this is, sorry, I'm Stephanie. I'm currently the only nephrology urology resident at Friendship. Um, and I wanted to present this paper. I know it's a little bit of an older paper, and it is all about like humans and rats and less so about like directly on our veterinary patients. But I did think it was interesting to like try and look back at some of these papers that go more into like the underlying physiology and mechanisms of some of the things we see in our patients. And this is something that I always forget exactly why we talk about like the sodium retention and like the overfill theory that we see in nephrotic syndrome. And so it's kind of using this as an excuse to go back and review some of the literature for myself. So there's definitely newer papers that are looking at this topic and that kind of do some more experiments. But this was one of the original ones that talks a little bit more specifically about plasmin and how they actually went about trying to find that. And I won't go too much into like nephrotic syndrome itself. This is one of JD's lectures from his recent talk about glomerular disease, and he talks a little bit about like underfill and overfill hypothesis, but I think this is where I first saw this paper referenced and kind of what prompted me to want to actually read into it. So kind of the theory now behind overfill hypothesis. And I think this is when we talk about nephrotic syndrome, it's still a like a pathophysiology that is not 100% straightforward, and in like which component of these different hypotheses is affecting different types of glomerular disease, I think is still something that we need to figure out. And certainly looking at this like specifically in canine or feline patients is not something that we've done yet. But this, so essentially this 2009 study by Dr. Svenningsson and company did a lot of these studies to try and start to explain some of this. So their hypothesis was that a defective glomerular filtration barrier in nephrotic syndrome is what's allowing these ENaC activating proteins into the tubular fluid, leading to stimulation of those epithelial sodium channels. And then just briefly, because I did not know what this is, but the model of nephrotic syndrome that they use in this particular paper is using a puromycin aminonucleoside nephrotic model. So PAN is a podocytotoxin. It causes inflammation, cytoskeletal rearrangement, DNA damage, apoptosis, cell death. It seems to maybe cause like a little bit of a minimal change disease presentation in some rats. So these are rat kidneys that are pulled up here. But it seems to be affecting especially like the endoplasmic reticulum and a lot of the inflammatory cytokines that essentially build up and lead to nephrotic syndrome. So this is used pretty widely in a bunch of different papers that are trying to assess nephrotic syndrome in mice. So the way that the study is set up is they ran like many different kind of little studies. So I'm going to try and just like go through each section and conclusion as they talk about it in the paper, and try and especially go into some of the graphs and tables and figures that they put up to try and understand how they got to the conclusion that plasmin especially is what is causing this upregulation of that sodium channel secondary to these nephrotic syndrome patients. So the first kind of conclusion was just that sodium retention is involved by this increase in renal in the ENaC channels. So what they did was they looked at a couple of different things, and I apologize because I don't know if it's because this paper is from 2009 or because they didn't want people to do what I did, which is copy and paste images directly out of the paper, but some of them are a little bit blurry. And you can see them a little bit better if you look at the paper itself. But the first step was just looking at different components of daily sodium balance. So in all of these graphs, the gray line is the control, and the black line are the rats that are treated, or the rodents that are treated with that pan model. And so what they first took was just their daily sodium intake, which they could measure directly by what they were giving to them in their food. The day 0 is when they got the injection of pan. And then they found pretty consistently that immediately after that injection, they saw a decrease in the sodium intake in those the pan rodents, and then it kind of maybe levels out a little bit again. The actual numbers of models they used in each of these was never very high. It's a little bit variable between the different studies, but from that daily sodium intake, they then calculated how much sodium was in their feces and had the difference be the daily intestinal sodium absorption. And then from that intestinal absorption, they also calculated how much sodium was in their urine. And what was left from that was their daily sodium balance. So what they found was pretty consistently around like the day 3 to 4 mark. You can kind of see in a lot of these graphs, there's a pretty noticeable difference in what their sodium is doing. And I think it makes sense. They've just given all of these rodents a nephrotoxin essentially, so they all have a little bit of an AKI, and then their kidney dysfunction normalizes a little bit. But what they found was that, so on that day 0 to about day 3.5, there is a negative cumulative sodium balance, and then it becomes positive thereafter. So just thinking about that as a concept, ultimately it means that they just have to be hanging on to more sodium. And if we go back and look at those graphs again for a second, what we can see is that especially like their urine sodium becomes almost 0 at a couple of days out after that first insult. So they're reabsorbing what is ending up in there. They so this next, let's see, oh gosh, I'm going in the wrong direction, sorry guys. So then the next step that they did from there was they gave these patients amiloride, these rodents amiloride. And what they found was, again, initially post pan injection, they did in fact have that decrease in, and this is looking at daily urinary sodium specifically, and then they gave them different doses of amiloride, a low dose of amiloride and a high dose of amiloride, and they saw that their urinary sodium went up a lot, so indicating that amiloride, which is an ENaC channel blocker, blocked that effect. So they're starting to reabsorb their sodium, or sorry, they're increasing their daily sodium excretion. So that was kind of the first step, was just saying what is happening to their urinary sodium in these nephrotic patients, like even independent of what exactly is causing those ENaC channels to reabsorb sodium or not. So then the next step was, okay, what exactly in the urine is causing these changes in urine sodium retention or not? And that's when they are saying, okay, we think that it's plasmin specifically in their nephrotic urine that's stimulating the ENaC activity. And again, this, for those of you on the more like science or academia side of things, you might understand a lot of these techniques. I spent a lot of time just trying to understand exactly what they were doing with some of these different studies. So they were talking about using these patch clamp techniques in a lot of the parts of this paper, and so I had no idea what that meant, and so I had to go look it up. So essentially, what they're trying to look for is differences in current, either within a cell or outside of the cell. And there's a couple of different ways that you can do this with how you attach the pipette to the cell, which changes how exactly the differences in voltage are sensed. So in this particular study, they used the whole cell patch clamp technique. So generally in those cases, they, at least in the website that I found that talked about this, they talk about using something like a strong current, something that disrupts that cell membrane. So the inside of the pipette, which is where they're sensing these currents, becomes continuous with the inside of the cell. There's a couple of other different ways you can try and make that that connection. And then really the goal is to try and look at least with the whole cell currents, either looking at currents flowing through the membrane or across the membrane potential. So this is especially used when you're looking at voltage-gated ion channels, like potassium or sodium channels. So obviously we're looking, a lot specifically at these epithelial sodium channels in this paper, but it helps to characterize the behavior of the different channels under different conditions. It does mean that it can be affected by changes in intracellular messengers. So if like your ATP is not standardized, it might affect some of those, how those channels work. But that's what the patch clamp technique is they're just trying to look at current as affected by sodium. So this is a bit of a busy slide, and I tried to make these images bigger, but then you could kind of just count the pixels, and that was not very helpful. So to kind of come to that conclusion about plasmin being an important player here, again, they did a couple of different studies looking at different components of specifically serine protease and how different factors and medications that can block that or block the ENaC channels affected the different currents that they were seeing across these cells. So this first graph up here, table A, they were looking at the black. So this first top black line was their control patient. The bottom black line is with nephrotic urine, and then you can't see it very well, but there's that gray line that's nephrotic urine and amiloride. So they took these cells, they got their baseline current, they then added both nephrotic urine and amiloride and showed that the current across these cells was very stable, but when it was just the nephrotic urine, so they washed away the amiloride, now the nephrotic, that nephrotic urine and the component in it that we're trying to see is causing that activation of those sodium channels. So it's changing how the sodium concentrations are moving across the cell. The B table in there is a different patch clamp experiment. So still looking at currents, but now they were also looking at aprotinin, which is a serine protease inhibitor, as well as amiloride, to see what their effects on nephrotic urine are. And the aprotinin, the goal is that you're inhibiting the enzyme so that it can't work on the ENaC channel anymore. So amiloride is blocking ENaC directly, and then aprotinin is blocking what is activating ENaC. And then vehicle is just like their control essentially on the nephrotic urine patients. And so they're showing that both amiloride and aprotinin are blocking whatever it is in nephrotic urine that's changing these currents. Graph C is a little bit similar. So now they're using chymotrypsin, which is a serine protease, so can activate these ENaC channels, and they're showing that chymotrypsin and the black bars are just the nephrotic urine. The white bars are nephrotic urine that's been heat inactivated. So they were warmed up for like 30 seconds, I think. They're essentially showing again that in these 3 rats that had nephrotic syndrome secondary to PAN, that when they were inactivated, we're no longer getting this enzyme activity. And then the Western blot, the protein bands in section D is looking specifically when the aprotonin is present versus not being present in these nephrotic versus non-nephrotic urine. And there's a clear effect on between the left and the right side bands, which is that when the aprotonin is not present, the PAN has this gelatinase activity. And then that last graph E, is looking at plasma versus urine. So the concept, the thought is that whatever is happening in these patients is specifically happening in their urine and is not because of changes in their plasma. And you can see that serine protease activity remains constant between control and affected patients in their plasma, but there's an obvious difference in their urine where the activity is much higher in the PAN patients. And then looking at the plasma activity, just to try and kind of confirm that this is truly plasmin that we're talking about, they used mass spectrometry on the fluid from these patients. They divided out by the supernatant and the precipitate, and they found that plasma and its fragments were present with mass spec. And so then kind of totally independent of nephrotic urine, they took just plasmin and exposed these whole cells to it, and saw, again, very similarly to the patients that had nephrotic syndrome, that plasmin activated that sodium current, so that that increase in sodium current, which is in the black bars in table 3E, is very high. And again, it gets inhibited by amiloride, which is blocking that ENaC channel. And then that gamma ENaC siRNA is a small interfering RNA, which knocks out the gamma subunit of ENaC. So similar to using the aprotonin is taking out the channel itself. In both those cases, when we're blocking the sodium channel, plasma no longer has the same effects on sodium current. And then that table on the far right, and actually the supplementary tables and figures in this one are kind of interesting. I could only download them like via the JSON website, so if you didn't see them, they're hiding over there. But they also had some interesting tables in there. But that's looking at it in a little bit of a different view, where they're having these currents of changes in sodium and showing the effect that having nephrotic urine, and then the PEFA block PL and that alpha 2 antiplasmin, again, are trying to inhibit specifically plasmin in this case. And 3D is looking at specifically the serine protease activity when there is or is not the knockout present. So this is how they're saying, yes, we think it's plasmin because we found it on mass spectrometry, and now using plasmin, we get very similar effects on sodium current and very similar tracings that we do with the nephrotic urine. So their third conclusion talks about how plasminogen specifically is activated by these tubular urokinase type plasmin activator. So now again, they took plasmin and plasminogen and just looked for evidence in these patients. And so this first band in the urine in A is showing that very consistently, if we think back to that kind of very original graph around that day 3.6, as they put in the paper, when patients become very proteinuric and have that increased sodium retention, it's also the same time that we see both plasmin and plasminogen start to appear in the urine. And if we compare that to their plasma, again, this is something that is specific to the urine, because while they have plasminogen in their plasma as they should, they do not have the same increase in plasmin. They also did some IHC staining on the cortical collecting ducts and showed that that urokinase type plasminogen activator is present. So, you know, we're trying to get down to the source of what is causing that plasmin to be cleaved. They also, so at this point now, they took amiloride and wanted to show that it could inhibit that urokinase type plasminogen activator. So if we compare this graph C to the one before, now even in these pan-injected patients, the low doses of amiloride block some of the plasmin. I'm going to flip back for a second. You can see how dark the plasmin bars are in the urine here, and they're much lighter with the low doses of amiloride, and with the high doses of amiloride are essentially absent. And 5D is another way of showing that when you have control patients, so not nephrotic, control and amiloride, and with the high doses of amiloride, essentially none of those have any of the banding patterns that would be consistent with plasmin, whereas when they just have nephrotic syndrome, and even a little bit with the low doses of amiloride, we are starting to see that there's that activity. And again, here on just kind of a little bit of a different format and a little bit of a different way of looking at it, now we're trying to see specifically like the plasmin to plasminogen ratio, where, right, the more plasmin there is, the lower that bar is going to be. And this is actually all sequential. So they gave the same patients their control period and then gave low dose and then high dose amiloride. So we see that the low dose decreases that ratio, but not as much as the high dose does. And at any point, if I'm going too fast or something is confusing, definitely let me know, and I will do my best to try and explain it. It's definitely a little bit different than like some of the other papers that I'm more used to reading from, just because it's so science heavy, but or like basic science heavy. But anyway, so moving on. So next result was looking at that UPA mediated conversion of plasminogen to plasmin, and that specifically is required for the activation of these channels. So they, and specifically the gamma subunit of that channel. So here they, did I go to? No. Okay, so they took the these African clawed frog oocytes and they pre-incubated them with either urine plasminogen or the urine, the UPA, and so that's what the first and then last two bars on this initial bar graph are showing. So essentially the same. So they're saying that just the presence of that enzyme or just the presence of plasminogen by itself does not cause changes in this current. But when we either give them chymotrypsin, which again is essentially plasmin, it's right, it's an enzyme, it's an activator, it's activating the ENaC channels, or we give them the UPA and plasminogen to get plasmin to activate the channels, now we've got much more evident changes in that current because the sodium channels are activated. So that's what that figure 6A is showing. And then they also showed by giving them amiloride. So in the 6D, there's the baseline, just UPA. Now we give them UPA and plasminogen. We see an increase in the voltages. And then if we give them amiloride, we totally block that. So yes, so essentially we do need both of those to be present to have activation of the channels. And then they also wanted to figure out what part of the ENaC subunit. So there's alpha, beta, and gamma subunits sections of the channel. And they they were just essentially trying to find the different banding patterns that would be consistent with the different subunits. So what this portion on the right is showing is they took these oocytes that had all three subunits present, and then they took one that just had the gamma subunit present. So the whole gamma subunit is supposed to be 87 kilodaltons. And then when we gave these patients either UPA and plasminogen or other serine proteases, they found that they had this 76 unit band present, which is consistent with like the cleaved gamma subunit, which makes sense because that's what it's doing. So they wanted to show it wasn't just the gamma itself, but that cleaved and activated version of it. And then we get to, so we said, okay, there's our ENaC has to be what is causing our sodium retention. It's the plasmin in nephrotic urine that is stimulating it by plasminogen, and we need the UPA to cause that to happen. So now they wanted to get more into, exactly what is happening on this sodium channel to cause that ENaC to be activated, and essentially about that gamma subunit. And so here they tagged this cleaving spot. So the spot between protosin and furin is a cleaving area for the gamma subunit. And they tagged it with this histidine marker. And in the presence of NTA ATTO 550, really rolls off the tongue, that marker should fluoresce. But that means that if that part of the subunit is cleaved, that marker will no longer be present to fluoresce. So when we look at this first one, this is essentially a patient that has the marker attached. It's not cleaved. We can see the fluorescing, very similar to control unit, although the control unit is a little nicer. But in both cases, yes, we can see obvious red. But now when we add plasmin cleaves this part of the subunit. We confirmed it because now there is no fluorescing. And again, the same thing with nephrotic urine. We have gotten rid of that marker, and we don't get any fluorescing. So great, that's confirmed it's the gamma subsection. And then the kind of final part of this was to confirm, because all of this is done in these murine models and with the African clawed frog oocytes, and with this pan-induced nephrotic syndrome that they were using to study. But they wanted to also show that this is true in human patients with nephrotic urine. So they took, I think, three different male patients that had nephrotic urine that were not being treated for it. And they essentially ran all of those same tests again, but using the nephrotic urine instead. And so I think this is interesting because now we're seeing, if we were to go back and pull up some of those other graphs, that they look very, very similar with the human nephrotic urine as the murine nephrotic urine. So this first graph at the top here, A, is looking at whole current traces. They expose, and again, it's that patch cell clamp model where they exposed the cells to either control urine or the nephrotic urine, and we can see there's a big difference in the amount of voltages that they're getting with these traces. They then used amiloride and antiplasmin and put that into the nephrotic urine, and again, with just the vehicle, the inactive form of this with just regular nephrotic urine, we can see a big increase in the sodium current, but amiloride blocks that effect, and so does antiplasmin. And then this C graph, which is looking at gelatinase activity, we see that the control urine, no gelatinase activity, human nephrotic urine, gelatinase activity. So we have these enzymes present. D, again, we're looking at serine protease inhibition now. So with the nephrotic syndrome, there's a lot of activity, but if we inhibit the protease either with the antiplasmin or the PEFA block, there's very little difference between the control and nephrotic urine. Graph E is looking at the presence of these different sizes of molecular weights and the immunoreactivity, much more activity with the nephrotic urine. And then they also looked for evidence with IHC staining to show that there is, in fact, urine plasminogen activator also present in the human kidney samples. So they kind of their summary from all of the previous studies, they showed that human nephrotic syndrome reacts like their murine model. So that's kind of, I just thought it was really interesting to actually try and read through how they figured this out and how they got from, those first steps to saying, yes, it is plasmin that is causing the activation of this channel. It happens in these patients because the plasminogen, normally present in blood, is able to leak through into the urine, get activated by that urine plasminogen activator, and upregulate those ENaC channels. More recently, and I didn't put very much because I always talk faster than I expected to, so it's a little bit shorter than I thought it would be, but more recently, there have been some papers looking at this. There's been a ton of papers, but I thought this was interesting because they're saying that essentially looking more specifically at urokinase type plasminogen activator. In this paper, they did use a little bit of a different model type. So instead of that pan-induced nephrotic syndrome, they used Potosin knockout mice. And they did some similar experiments where they took these Potosin knockout mice, they exposed them to amiloride, they exposed them to, or their urine to anti-urokinase type plasminogen activator, and they compared it to controls. And they found that there was a urokinase dependent plasminogen activation and cleavage of that gamma ENaC subunit, which is what that 2009 paper was showing, that contributed to sodium accumulation. But interestingly, so this came out, or at least it was received February 12th, 2019, published August 12th, published 2 days earlier, or I guess a few months earlier, but received a couple weeks later, was a paper that maybe suggested something very different. So these are both published in Acta Physiologica, and essentially published at the same time as each other. This paper is saying it's not essential, that the UPA is not essential for that ENaC-mediated sodium retention in this experimental model. Now, this paper was a little bit different from the other one. Instead of using the Potosin knockout mice, they used a doxorubicin-induced model. They also looked at the African clawed frog oocytes and, again, exposed them to amiloride, and used also in here a model of uroplasminogen activator deficient mice to see what would happen. And they found that in their patients, although they did agree that the urine plasminogen activator does allow for conversion of plasminogen to plasmin, they did not find that it was absolutely dependent on that, because the knockout mice, the UPA knockout mice, would still have activation of sodium retention. So they're saying that there's other things in the urine that can do this, that UPA is not essential for this, and which is obviously a little bit different from some of the other papers. And then if you really want to get into it, this then spawned an editorial, which spawned a rebuttal to the editorial, and then an author's reply to the rebuttal to the editorial, which all came out within, again, about a year of that original one. But I'm did not put anything else more in these. So if you want to go read a lot of rebuttals to each other, I think these are out there, and it shows probably that this is still a little bit of an evolving field to understand the different components that are truly responsible for this. And I think certainly it makes sense that there might be more than one enzyme present in these patients. Obviously, what's always a little bit tough is to say how much of the models done using induced or knockout mice or oocytes from African clawed frogs, how much is that translatable to actual patients that have naturally occurring forms of nephrotic syndrome? Does it matter if it's a GN from glomerulosclerosis versus like Alport syndrome versus you know, immune complex GN? Does it mean that there's different types of plasminogen or other kind of precursors of enzymes that are going to their urine? I think probably, right? Probably there's multiple roles at play here, but this was, I think, for me, kind of just the start of trying to understand a little bit better the overfill hypothesis. I also think, looking at this, I have not reached for amiloride and as a treatment for any nephrotic syndrome patients. It seems like it's probably expensive. I'm not sure because I haven't used it yet, but this paper, I think, really like maybe supports the physiology behind that and trying to, we have all of these edematous patients, and because they have nephrotic syndrome, their hydration status is sometimes a little bit difficult to control, and it's so easy to overload them. And like we get all these patients that come to us for things like renal biopsies, and they're just, they're bags of fluids because everyone's first choice when a dog comes through the urgent care is to stick it on fluids. And so maybe this is something that can help, something like amiloride can maybe help manage these patients a little bit better, get them feeling better. But I will stop there and see if anyone else has any thoughts.
Nice presentation, Steph. That was great. We've used amiloride in a handful of patients that were having nephrotic edema, and the dosing is a little bit hard to extrapolate because it's in adults, it's just dosed like per person. I think it's maybe 5 to 10 milligrams per human. So I've always just kind of tried to extrapolate on if they're a small human or a medium-sized human, the patients that we're looking at. But I think for pediatrics, at least, they actually have a mg per kg. And I think it's somewhere like maybe 0.6 mg per kg is the dosing. So I've tried to extrapolate that and use it in animals. And I feel like we've seen some positive effects, but it's too hard, I think, to really be able to say it's specifically from the amiloride. Because as you said, like many of those patients come over and they've been already completely volume overloaded. Because not only are they hospitalized because they're azotemic, well, they're also hypoproteinemic, and then they were slammed with fluids, and now they're even more edematous. So some of that edema is going to be just being hypervolemic and needing less fluids and have them pee it out. And some of the improvement is probably going to be from amiloride as well, too. So I think it has a lot of promise, and I think that it has, I personally am a bit more comfortable with that compared to the current recommendations and the IRIS guidelines to use furosemide. I think that furosemide probably has an increased risk of causing a volume depletion. But then also, if we think about furosemide and what it would do is, okay, well, now you're going to flood the tubule with sodium. So more is available in the distal nephron. And then if the ENaC is still activated, we've just provided more sodium to be reabsorbed. So there's a chance that you're basically ENaC loading with giving Lasix. And perhaps the improvement in edema that you might see is once you've just caused enough volume wasting, and they dry out that way. But physiologically, it might not be the ideal scenario if the distal nephron is really the source of that avid sodium reabsorption. So I've been turning to it more and more, but it'd be interesting to see if other people have been using it and see if we can actually try to collect some data to show what its efficacy may be. Um, but that's going to be hard because, again, most of these patients are probably going to be on multiple therapies. But I think it has a lot of promise. I'm not sure if anyone else has used amiloride yet to treat nephrotic edema. I know Rachel has. She gets that biopsy, and that's the first thing that she's doing. She's reaching for that bottle of amiloride for her patients.
No, I mean, sometimes we get animals with the history that you've described, and I'm very good at making sure I get your consult on those cases, but maybe that's something that we should, because I know you kind of have a little bit of a boilerplate for how to treat in general, depending on diagnosis, but maybe a blurb for that in your boilerplate of might be promising, but more data is needed.
Yeah,
Would be good for that.
right. Because honestly, it's not like we have data on furosemide either, looking at
Yeah.
that helps nephrotic
And I think
edema.
sometimes I wonder with the pretty old now NC State paper that was talking about animals that have full-blown nephrotic syndrome versus not when they are, even if they're, moderately to markedly proteinuric, but they don't actually have the edema or the ascites and stuff like that. And if they do have full-blown nephrotic syndrome, they have a much worse prognosis.
Yeah, I think it's 4
Um,
days survival with your
Yeah,
ischemic
it's like something
nephrotic.
really bad like that. But that concept of like, well, if that is management of ascites and effusion and how difficult that is, then being a little more aggressive with getting that animal to return to a non-acidic, acidic, ascites-filled state, non-effusive state, um, would maybe be a goal of therapy instead of, obviously you got to treat the glomerular disease as well, but making sure you return back to a non-balloon dog is also very important for owners.
Yeah, and I'm sure it makes them feel terrible. You think
Yeah.
of how squishy they are, and you think
I
of
mean,
elder
people that have
husband.
ascites feel terrible, so I
Oh
would
yeah.
assume a dog that has ascites feels terrible.
Yeah, I just think of like their gut edema, and they're probably not going to absorb nutrients well, or feel super even more nauseated than how they were before. So, it's probably something we should be having as a priority, because if we can dry them out, they'll probably feel better, and all of our other therapies will maybe be a bit more effective as well. But yeah, I do think that a nephrotic azotemic patient is very challenging to manage, and historically the prognoses are bad, or going to require a lot of intensive management, and a lot of clients are just going to stop once they get bad news. But maybe we could get better outcomes if we can just get them under better control sooner.
Are you using amiloride with other diuretics or
No, no, I'm just
okay?
using amiloride.
Hmm.
Yeah, just amiloride for that, specifically for the nephrotic edema.
Yeah.
For other edemas, like PLE edemas or things like that, I think they probably do a little bit better with spironolactone and hydrochlorothiazide. But yeah, specifically for nephrotic edema, that has been my go-to drug for a while. But I think it's less common that we have these patients coming to us that have a pure nephrotic edema that hasn't been fluid overloaded. I think so much of that is just they were hospitalized and fluid overloaded with getting tons of salt water. And if we can just get them to diurese out the salt water, then they're going to dry themselves out. And then maybe they're not going to need anything. So in those patients, depending on how edematous they are, I may or may not use amiloride versus just giving them some time and not giving them extra fluids. And then they might not need it because they might no longer be edematous once they're dry. So there are other patients that come that are edematous that I don't use it just because they just need time and need to return to normal bulimia once again.
Yeah, I feel like all of everything for like the last year's just come after 3 days on IV fluids at high rates to diurese out the kidneys.
Yeah, more often than just coming in being edematous from the start. I think that's much less common, but that's kind of the opposite in people. Like they'll be nephrotic as they're coming in the door with like the hind limb, pedal edema, and just feeling really gross. And I think it's just probably easy for people to recognize like my foot is swollen at the end of the day, and this is weird. But less so in our patients. But I think it's a cool tool to have, and physiologically, I think it's a sound approach. So definitely worth more investigations. It would be really cool to see if we could get some type of assay that we could look at plasminogen concentrations and do like a urine plasminogen creatinine ratio in our proteinuric patients, comparing that maybe across the board when we're getting biopsies on them. And if there is a difference associated with whatever the pathologic lesions might be, um, I feel like that's probably not too hard of an assay to develop unless there's just a lot of things that are going to cross react with it. But it'd be interesting to see if someone could kind of set that up for us, because I feel like we could have a lot of samples that we could get analyzed. Let's just have Jess specifically look for that on her SDS page and then
They,
cut out the gel and then run mass spec on it, and then she can quantify it for us. But
yeah,
you,
we it's just those 76 kilodalton bands, that's all.
yeah, yeah,
Just aim for those. Um, Dr. Cheney was asking how you dose the amiloride, which you
yeah.
said is
So again, like 5 to 10 mgs per person is the normal dose of amiloride. So I would often start, for small patients at like 2.5 milligrams twice a day, and then kind of increase from there. I think the highest dose is like maybe 60 milligrams per day. So it actually can go up pretty high. But the way that they dose it in peds is 0.6-ish mgs per kg. And that can be once or twice a day. I've typically been giving it twice a day. And yeah, so that's how I've stolen the dose from people. But again, I don't know if that's the most effective dose to use or not, but it seems to have had anecdotally some effect with everything else we do too.
have you ever looked at any of their urine sodiums afterwards? Like pre and post?
No, I haven't, but I also think if they were volume expanded with fluids, that's going to be another factor that you'd expect their urine sodium to be affected by their spontaneous increase in sodium per day from their fluid therapy, and then it goes away. So I don't know how to specifically look at that and be able to say the effect of their urine sodium is specifically because of the drug and not because of the just the time frame of when they started getting fluids and when it was stopped. But it would be an interesting thing in patients who were naive to fluids to look at that before and after. But I can't say I've had that luxury to see that patient. Cool. Well, if anyone else uses it, let us know. It'd be cool to try to get a case series together or something to show what this drug may or may not do. And I think it has promise so far. So be cool to keep trying it and see what we get. All right. Well, I think unless we have any other questions or comments, I think we are good to go. Summer, was our next session scheduled?
It's actually next Tuesday.
Excellent.
Yeah, so we have another one next Tuesday, also at 12 Eastern.
Okay, and Will, is that yours that you're doing next week, I think?
Yeah, it is.
Cool. And then we'll likely be needing to update the schedule probably in the next month or two. As we have a handful of new residents that are joining, we'll have to get some additional journal clubs scheduled for them. So just keep your eyes peeled, and we'll certainly send out an email update once we do update the schedule. But with the new resident load, it might even need to increase to a weekly episode.
Yeah, that's what we're looking at.
Yeah, I
and
think by
hoping for,
taking some
so.
time off for conferences and holidays and things like that, we'll probably be going up to just a standing weekly time. So hopefully that'll make it easy for everybody to attend, and for those people who can't attend live, then we'll always have the recordings that will get posted as well. Cool. Well, thanks everyone for joining. Awesome work, Steph. Great job. And we'll see you guys next week.
Thanks.
Thanks. Bye.
Yeah.